My name is Alvin Go, and I direct the Robotic Urologic Surgery Training Program here at Houston Methodist Hospital in Houston, Texas. First, I'd like to thank the British Journal of Urology editors for the opportunity to share some of our most recent work in robotic surgical training. Robotic surgery continues to grow in its application in urologic surgery. We know that surgeon technical skills have been directly related to patient outcomes. One key question that arises is how to best train up-and-coming surgeons in robotic surgery in a safe and efficient manner. With training hours restrictions and medical legal considerations, more emphasis has been placed on acquiring robotic skills in the simulation suite first prior to entering the operating room. While there have been several training platforms developed to teach robotic surgical skills in a simulated environment, a clear connection between simulation-based performance and clinical robotic performance has yet to be established. In this study, we sought to establish the connection between simulated robotic tasks to intraoperative performance during robotic prostatectomy. We assessed robotic performance of 21 urologic surgeons with varying robotic experience in a simulated environment using our previously validated FIRST exercises and virtual reality tasks using Da Vinci simulator skills and correlated these to robotic performance in the operating room during the endopelvic fascia dissection of a robotic prostatectomy. The clinical performance was blindly evaluated using our standardized clinical robotic skills assessment tool known as GEARS. In this study, we had 4 experts and 17 trainees. We found a strong correlation between simulated performance and robotic surgical performance as measured by GEARS. In this scatter plot, composite virtual reality scores are plotted on the x-axis, and GEARS scores or clinical performance scores are plotted on the y-axis. There's a strong positive correlation between virtual reality performance and clinical performance during robotic prostatectomy. The right figure shows inanimate FIRST scores compared to GEARS scores. Similarly, performance on inanimate robotic tasks correlates strongly to robotic surgical performance. As we stratify performance by training experience, we see a stepwise improvement in robotic simulated performance as well as clinical performance. Of note, in this study, we identified a stronger correlation between inanimate exercises and clinical performance compared to performance in a virtual reality space. This finding highlights some of the remaining limitations of virtual reality training and the need for training across multiple environments. This is the first study to demonstrate a positive association between robotic performance using validated models and clinical performance in the operating room. This work has provided the motivation for the development of a proficiency-based robotic training curriculum. Future efforts in this area will be aimed at validating this curriculum and assessing whether training to proficiency on validated tasks will result in improvements in robotic clinical performance.